Quota 4. Quota 4 will involve myself, Dr. O'Hare, Dr. Shivachar, and Dr. Zhang. It's only a 2-hour course, which we don't like too much, because each lecture is only about 15 minutes before you get started, the time is up. However, we'll manage to do what we can. So the first section is a continuation of cancer, but we will be concentrating on breast cancer and prostate cancer and cancer of the cervix. If time permits, we will look at some combination drugs that you use to manage lung cancer. And you'll see in the handout there that we also have some information on skin cancer. That's just there for your own reading. We never get to skin cancer, but I just put it there for your information. So that's the first section of the course, and then after that you go into GI and so on. There will be 4 intrasessional exams. The final is cumulative, and because it's just a 2-hour course, on the final you just have 50 questions, but it would be cumulative. And the rules regarding cell phones and other devices, the rules are the same. If your phone accidentally goes off, don't waste our time, just pack up and get out. Okay. The rest of the syllabus should be available by the end of this week. But what's important, you already have, and that's your lecture schedule. And you should also have in there some description of breast cancer on Blackboard. So that's essentially what we will start off with, unless there's a question about that introduction. Okay. So, no questions. The first thing we'll do is to look at the therapy limiting toxicity of some drugs and how you manage those. We can also mention some other adverse effects of certain drugs that are commonly seen. We may allude to mechanisms of action of some of those anti-cancer drugs that you've already come across. So if we start off with, say, bleomycin, that's one of those anti-cancer drugs. And you see that in your handout there. The primary adverse effect of that drug, or the TLT, is pulmonary fibrosis. And that pulmonary fibrosis is actually due to it involves the NLRP3. So in other words, when you give bleomycin, you can see NLP3 protein being converted to the NLP3 inflammasome. activate caspase. So your caspase enzyme will be involved, and then you will get a production of some cytokines, like interleukin 1, particularly interleukin 1B, and your interleukin 18. So those cytokines will be produced, and those are the ones that will then cause that fibrosis in the lungs. Usually, if, or very often, if the drug produces that pulmonary fibrosis, it is hard to reverse. Very hard to reverse. So you don't want to get to that level of getting pulmonary fibrosis with your bleomycin. So dexamethasone can work, to help minimize the deleterious effects of that pulmonary fibrosis. So you can see dexamethasone being used when bleomycin is given. Imatinib also works to manage that pulmonary fibrosis. Tacrolimus is another agent that can work. There's a drug called pirfenidone, which also seems to help in managing bleomycin-induced pulmonary fibrosis. So that's what you see with bleomycin. On your list there, you also have, say, a drug like cisplatin. And we know that cisplatin, or your platinum complex agents, are highly nephrotoxic. They're highly nephrotoxic. Cisplatin is nephrotoxic, it is neurotoxic, and it also has a lot of optical disorders or adverse effects. But the TLT for cisplatin is nephrotoxicity. And you can reverse that nephrotoxicity by giving amylfostin. Okay, and that is like a specific antidote to cisplatin overdose. And of course, your cytoxan, which we had mentioned last semester, cyclophosphamide, we know that will cause hemorrhagic cystitis. That's the TLT for your cytoxan. And you can manage that, of course, by giving hydration. You hydrate the patient, of course, and you want to give mucomist or give mesna for the management of that hemorrhagic cystitis that you see with cytoxan. And your anthracyclines. The anthracyclines, and of course, if you talk about anthracyclines, we're referring to doxorubicin, daunorubicin, idarubicin, epirubicin. All of those are anthracyclines. How do the anthracyclines work? What's the mechanism of action of your anthracyclines? Okay. Means you didn't study during your vacation. Vacation time is the best time to study, actually, because you have no exam pressure. And unfortunately, that's when students don't even want to touch the book. But that's the best time to actually grasp the information, no exam pressure. But your anthracyclines, like say doxorubicin, can do 3 or 4 things. One, they can alter the cell membrane of that cancer cell, okay? So that the cancer cell, the integrity of the cell membrane is no longer there, and the cancer cell will not be viable. 2, anthracyclines can inhibit topoisomerase, and they inhibit topoisomerase 2. Okay, so that can, of course, affect the DNA in terms of replication. And 3, your anthracyclines can generate some reactive radicals. Okay. So when you give your anthracyclines, you can see the production of your reactive oxygen species. And of course, those are radicals that will come from the quinones. Your anthracyclines will be converted to quinones, mainly semi-quinones. The semi-quinones will then generate hydrogen peroxide, H2O2, and the hydrogen peroxide will yield very reactive hydroxyl groups, which can attack the DNA and RNA of the cells, of the cancer cells. But unfortunately, that would also attack the cells of the cardiac tissue, the heart, the normal cells. And that's what can lead to that cardiomyopathy, which is the therapy limiting toxicity of your anthracyclines. Okay, so in order to prevent that cardiomyopathy or reverse it, then you want to give a drug that can that can gobble up or destroy those reactive oxygen species or your hydroxyl groups that are highly reactive. That can gobble up those radicals. 2 enzymes will help you do that. Dismutase and you also have a reductase that can do that, and a catalase that can also do that. And so, if you can increase the activity, especially of this dismutase, you can decrease, the activity of those radicals, and so if you decrease that, you get a decrease in the incidence of that cardiomyopathy. And one drug that would help to do that is your dexrazoxane. So that is why we say that Zinecard is like the specific antidote to the cardiomyopathy caused by your anthracyclines. So it goes back to understanding the mechanism of action of your anthracyclines, which is the generation of those radicals. And you have to suppress all this reactive species. And then fourthly, your anthracyclines can cause intercalation. They can intercalate on your nucleobases. So if you cause an intercalation of those nucleobases, then the DNA cannot function. In other words, you cannot have very good separation of the double helix, and so you will not get replication of the genome, and then the cells will not grow that way. So those are the four mechanisms by which anthracyclines work, and one of them, let's see, we can use to explain cardiomyopathy, as you see, is the anthracyclines. There's a drug that belongs to the anthracendione, mitoxantron, that behaves like anthracyclines, but your mitoxantron does not produce the cardiomyopathy that you see with your anthracyclines. So anthracendions behave like anthracyclines, but they do not produce that cardiomyopathy. And so we know the specific antidote for that. Your methotrexate, the main TLT will be bone marrow depression or myelosuppression. And you can also have that hemorrhagic enteritis. Those are the two TLTs for methotrexate. Anytime you have myelosuppression, you can often manage it by giving erythropoietin. So you can see that in your Epocrit, erythropoietin. RNS is another agent that you can use to manage myelosuppression. That's your diabetic protein, poietin. That's the generic name, and RNS is the brand name. So you can always use those to manage or reverse the myelosuppression or bone marrow depression. Bone marrow depression would also be an adverse effect or the TLT for your 5FU, 5-uracil. It's primarily of its TLT is myelosuppression. You can use those. But we know that 5FU can cause a host of other adverse effects. And if you give too much of 5FU, you can reverse that toxicity by using Vistogard. Uridine triacetate is what you have in Vistogard. So Vistogard is a specific antidote for 5FU overdose, or even for your capecitabine. If you gave too much of capecitabine, you can use Vistogard to reverse the adverse effects. Etoposide also produces a TLT that is mainly leukopenia, so it still has to do with the bone marrow. Okay, so leukopenia can result from your etoposide administration. And how does etoposide work? How do you classify it? It inhibits what? Etoposide would inhibit topoisomerase. Topoisomerase. And that would be topoisomerase 1. Your inhibitors of topoisomerase 1 are things like teniposide, etoposide, and irinotecan. All of those can inhibit topoisomerase carcinol is 1. And so the TLT for that is leukopenia. So it affects mainly your white cells or white blood cells. And to reverse that, you can give your GCSF, granulocyte colony stimulating factor. Okay. That will help to reverse that TLT. Okay. Then you go to your vinca alkaloids. The vinca alkaloids, of course, you're talking about vincristine, vinblastine, vindesin, vinorelbine. So for your vincristine, vinblastine, vindesin, the TLT there will be your myelosuppression, bone marrow depression. For your vinorelbine, it will be bone marrow depression, but for those other 3, it would be your neuromuscular abnormalities. So vincristine, vindesin, vinblastine, all of those will be neuromuscular abnormalities. But for your vinorelbine, it will be myelosuppression. Okay. And the neuromuscular abnormalities, the manifestations can be things like your peripheral neuropathy, it can be dysesthesia, sometimes it can even be seizures. You can see the manifestations being seizures, peripheral neuropathy. So if it's caused by all these cancer drugs, we call that chemotherapy-induced peripheral neuropathy, CIPN, chemotherapy-induced peripheral neuropathy. Yeah, you see that a lot with your vincas. Cisplatin can also produce that CIPN. We can also see it with your taxanes. The taxanes can also produce a lot of your chemotherapy-induced peripheral neuropathy. Okay, and the taxanes, which would include your paclitaxel, docetaxel, cabazitaxel, all of those, the TLT happens to also be your myelosuppression. But your taxanes can also produce a lot of mucositis. And if you break that down, you will get an inflammation, itis of the mucosal tissues of your GI tract. Everything from the mouth all the way down to the anus can become inflamed when you give taxanes. And it's a very common adverse effect of your taxanes. And fortunately, you have a specific agent that can help to manage that, and that's Kepivance. So you can use Kepivance to reverse or manage that major toxicity of your taxanes. Okay. Allotinib, the major adverse effect of allotinib, which carlotinib, has to actually do with the skin. So you can have severe skin rashes and skin reactions that may lead to discontinuation of therapy with your carlotinib. That one is, is a little unusual. But you see that also with your NNRTIs. They produce a lot of skin reactions that may lead to cessation of therapy with those drugs. Okay. Now, some drugs can cause extravasation. Okay, so basically extra out of vas vessels. Okay. So you give the drug, it eats through the blood vessel lines and it gets into tissues, and it can cause tissue necrosis and severe pain. Okay. So if a drug causes extravasation, you want to elevate the limb that is affected, either the arms or the legs. Elevate the limb, that's one modality of management. And you can give sodium thiosulfate, STS, sodium thiosulfate, and also that helps to manage extravasation. Or you can give some cold compresses to manage that the extravasation. Okay. If an anti-cancer drug works rapidly, drugs like your beta alkaloids, for instance, and your platinum complexes, that is cisplatin, carboplatin, oxaliplatin, omeplatin, tetraplatin, all of those are platinum coordination complexes. If the drug works rapidly like that, it usually produces hyperuricemia, which one would then need to manage. How do you get hyperuricemia? From your beta alkaloids or from your platinum coordination complexes? It is because of rapid destruction of your cancer cells. Okay. The DNA of your cells or the RNA of your cells will come from your nucleotides. Nucleotides will be in your genome, that is your nucleic acids. Okay. And when you're destroying the cells, it means that the cells or your genomes are being broken down. So your ATP will now go to your ADP. Okay, so triphosphate to diphosphate, and that will then go to monophosphate. Okay. So in this case, you're looking at adenosine triphosphate, diphosphate, monophosphate, and then you have the adenosine itself. Okay. And the adenosine will be converted to your inosine. And that inosine will then be converted to your hypoxanthine, and the hypoxanthine, of course, to xanthine, and the xanthine will then go to the formation of your uric acid. And then you would excrete the uric acid. And you can do the same thing on the GTP side. So we go to your GTP. Of course, all these are purines. And then monophosphate. And then you get your guanosine. And the guanosine actually can go directly to apoxanthin or even straight to xanthin. It does not have to go to your inosine. So the way you form your genomes, or that is your nucleic acid, you just reverse it, and that's the way you would break them down. If you're, we mentioned de novo synthesis of your genomes. In this situation, if you start with your phosphoribosylpyrophosphate, pyrophosphate, you can get your inosine monophosphate. And inosine monophosphate can eventually go to, to your AMP, which can go to ADP and then on to ATP. And so this is like the central part of your genome buildup and destruction. Okay? And inosine monophosphate can then yield that inosine, which can go to apoxanthin, and then xanthin, and then get uric acid production. Okay? So this whole system, it can go up from adenosine all the way to ATP and to IMP and then to your genome. The same thing with your guanine or guanosine. Okay. So apoxanthin will go to xanthin in the presence of xanthin oxidase. And the xanthin can go to uric acid also in the presence of xanthin oxidase. Okay. And so you gave a vinca alkaloid, you gave it platinum coordination complex drugs, you get rapid breakdown of cancer cells, a lot of ATP and GTPs will be produced. It will eventually come down to xanthin, which will now form your uric acid. That's an enzyme that is called uric oxidase. Uric oxidase can break your uric acid down to allantoin. And the allantoin is very water soluble, and it can very easily be excreted in urine. Unfortunately, uric oxidase is not very active in humans. Okay? That's why we excrete uric acid through the renal system. Okay? So we excrete a lot of uric acid through the renal system. About 50% of your uric acid load will be reabsorbed. That's how the cycle continues. So you form uric acid, a lot of it goes out in the urine, 50% of it actually gets reabsorbed, and that cycle continues until you get rid of your uric acid. Of course, if it accumulates, then you get gout or gouty arthritis. And so when you give your vinca alkaloids or your cisplatin, you can get an accumulation of uric acid, so you get hyperuricemia, and that can lead to gout or gouty arthritis in that cancer patient. And so to prevent that, then of course you can administer a drug that would inhibit XO, a drug drug that would inhibit your xanthine oxidase, so that xanthine does not go to uric acid. And of course, we know drugs that can do that. Your allopurinol can do that. Levodopa can also do that. So you're inhibiting xanthine oxidase with those, and you can then prevent the occurrence of hyperuricemia when you're giving your Vincas and your platinum coordination complexes. Or you can increase the excretion of uric acid by decreasing the reabsorption into the bloodstream. So if you use a drug like Benamid, you can do that. You decrease the reabsorption of uric acid, from the renal tubules back into the blood system. So you decrease accumulation of uric acid that way. That's a drug called lesinuride. Lesinuride also inhibits what you call your urate 1, which is a transporter. That is something that can transport your uric acid from the renal tubule back into the bloodstream. So if you inhibit urate 1, then you'll be inhibiting reabsorption of uric acid. That will help to manage the hyperuricemia. That lesinuride can also inhibit your OAT4, organic anion transporter, which is another transporter that brings your uric acid from the renal tubule back into the bloodstream. So you can see lesinuride helping with that. Now, you have a drug called rasburicase, and one that is pegloticase. Okay, so those are enzymes. These are actually recombinant DNA technology produced urate oxidase. This enzyme that we said is not active in humans, you can make a copy of that enzyme, through recombinant DNA, and that's how these two drugs came into being, rasburicase and your pegloticase. And if you remember, there you see that PEG again, pegylation that we discussed last semester. So these two drugs are actually analogs of your urate oxidase. So how they work is to actually convert that uric acid to a lanthanum. So that totally nullifies your uric acid load, because once you form a lanthanum, that very easily goes out through the urine. Extremely effective drugs, but extremely expensive drugs. So that's why you don't see them used that often. But those are recombinant DNA technology produced urate oxidase, which will convert your uric acid to a lanthanum, and then your hyperuricemia would basically disappear. So those are antidotes, if you will, to the hyperuricemia that can be caused by rapidly acting cancer drugs like your cisplatin or platinum coordination complex, and by other agents like the vinca alkaloids. Okay. So those are mainly the first few things we want to talk about. This should be page 1 of your handout. All right, so having cleared those, well, let me just mention one more thing that you already know. You can also use a rescue agent when you give methotrexate or your 5-FU. Okay, so now we can start with your breast cancer. And by the way, the dean is supposed to come and meet with you guys. What time is it now? Like 8:42? Yeah. Okay, so you're supposed to come in 3 minutes. All right. So, but we'll start off with breast cancer. Okay. By definition, your breast cancers are carcinomas. Okay. So when you use the term carcinoma, that means that the cancer arose from an epithelial cell. Okay. So that's what we call a carcinoma. You use the term sarcoma when the cancer arose from a connective tissue. So if we're talking about your collagen, your ligaments, your bones, all of those have connective tissues. The skin, part of it has connective tissues. So if it comes from a connective tissue cell, it is a sarcoma. If it comes from an epithelium or epithelial cell, then it is a carcinoma. Okay? And if that epithelium happens to be in a gland, that's when you use adenocarcinoma. Okay? So that's the separation. So breast cancer is most often a carcinoma, because it usually comes from an epithelial cell, okay, or epithelial tissue. Now, you just say breast cancer, but there are different or very different types of breast cancer, and that's why I've listed this up here. Your breast cancer is actually either a lobular source or lobular cancer or a ductal source. In other words, it either comes from the mammary duct or from the mammary lobules. And so you say you have many different types of your breast cancer. The one that you find most often is the infiltrating ductal mammary carcinoma, that is breast cancer. 70% of your breast cancers are of this infiltrating ductal mammary carcinoma types. And within that type, you can also see some squamous cells, okay, that can be changed, to a malignant cell. Okay? And this is the type that you find most often in black females. Okay? It is ductal, that is, of course, within the duct of the mammary gland, but the cells are usually squamous cells. That you see there. Okay, and You have papillary, medullary, adenocystic. Actually, as you see, adeno, it means gland. So the cancer cell or the malignant cell derives from a path of secreting gland within the mammary gland itself. That's the adenoid cystic. Not very common, but it does happen. So, and the lobular in situ, that's the easiest one to take care of. It occurs in the lobules, and it's usually just stationary, and it's very small. You just yank it out, just excise it. That's very easy. This is infiltrating lobular, and this is inflammatory carcinoma. This is also common with inflammatory carcinoma, lobular breast cancer. So those are your different types of cancer that you can see. Okay, what is the etiology of breast cancer? Unknown. Okay. So etiology is not known. What we do know is several factors that can place one at a high risk of developing breast cancer. Like all cancers, we mentioned this last semester, all cancers would have an initiator and would have a promoter. An initiator will be something that changes the genome, in that cell to make it turn malignant. And then a promoter will be something that creates an environment that is conducive to the proliferation of those cells. So you always have an initiator, you always have a promoter. But why a particular somatic cell turns malignant, that is the etiology, the real cause is still unknown. But like I said, you have certain risk factors of cancer cells or breast cancer, basically. One is familial risk factor, that is inheritance. Who's that? Under there? Okay. Yes, it's that big company.
Hi, class.
Okay.
Morning.
So,
Is it okay we come in?
yes, we'll pick it up from there.